Hello everyone, my topic today is surgical treatment of endometrioma. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University, and this is my scientific blog site, dralamusbah.blogspot.com. What we wanted to know about surgical treatment of endometrioma and about endometrioma in general. The definition and the prevalence, the pathogenesis of endometrioma, the treatment goals, surgical treatment, general recommendations before surgery, laparoscopic surgery for ovarian endometrioma, conservative surgical treatment of ovarian endometrioma, including cystectomy, ablation by laser or by plasma energy, electrocoagulation, or combined techniques, or lastly, three-step approach. All these under the topic conservative surgical treatment of ovarian endometrioma. Lastly, we wanted to know about oophorectomy as a last line of treatment. So, as you see in this picture, this is the ovarian cyst called chocolate cyst or endometrioma. It's one of the pattern of endometriosis, three patterns commonly seen: the peritoneal endometriosis or ovarian endometrioma or deep infiltrating endometriosis lesions. So, our target today, how to manage ovarian endometrioma or chocolate cyst, guided by the recommendation of the European Society of Human Reproduction and European Society of Gynecologic Endoscopy and World Endometriosis Society in 2017. So let us go to see our lecture. Let us start with the definition of endometrioma. Is a cystic mass arising from ectopic endometrial tissue within the ovary. It contains thick brown tar-like fluid which is altered blood, like this in the picture. This brownish fluid is altered blood coming from the cyst after its puncture or accidentally punctured during laparoscopy, when I'm doing laparoscopy for one of my cases. This is the ovary before puncture of the cyst and the release of this chocolate material for the same case. Okay, so this is chocolate cyst of what is called endometrioma. Endometrioma is often densely adherent to surrounding structures, such as fallopian tubes, peritoneum, and the bowel. And of course, these adhesions cause many problems as regard the fertility of the patient, also cause many pains, either during menstruation, which is dysmenorrhea, or even without menstrual flow during the whole month, there is chronic pelvic pain. So, what about the prevalence of ovarian endometrioma? Endometrioma are probably the most commonly diagnosed form of endometriosis. Why? Maybe because of the relative ease and accuracy of ultrasound diagnosis. Yes, this pattern of lesion of endometriosis can be diagnosed easily nowadays by transvaginal sonography. As you can see in this picture, this is the characteristic ovarian endometrioma or chocolate cyst with low-level homogeneous echogenicity and hyper-echogenic wall foci. This is characteristic of ovarian endometrioma. This is one of my cases. I did transvaginal ultrasound and the diagnosis was confirmed by laparoscopy later on. So, the endometrioma is a very common problem and very common pattern as regard pelvic endometriosis. Although their exact prevalence and the incidence are not known, they have been reported in 17 to 44 of women with endometriosis. And this is, of course, a very big incidence. The presence of ovarian endometrioma has been reported as being a marker for deep endometriosis. What is the pathogenesis of endometrioma? It depends on some theories trying to explain endometrioma, like invagination and the subsequent collection of menstrual debris from endometriotic implants, which are located on the ovarian surface and the adherent peritoneum. Another theory, colonization of functional ovarian cysts by endometriotic cells. Another theory, coelomic metaplasia of the invaginated epithelial inclusions. So, what is the treatment goals? The goals of endometrioma treatment are to relieve symptoms like pain or mass or dyspareunia, prevent complications related to the adnexal mass like adhesions, like rupture or torsion or infection, exclude malignancy. This is very important also. Improve subfertility and preserve ovarian function, and this is very, very important also. So what about surgical treatment, which is our target today in this lecture? As you can see, this is the laparoscope. Insufflation of the abdomen first, then insertion of the laparoscope, then 3-port technique to deal with ovarian endometrioma. Okay, surgical treatment is the mainstay of endometrioma management when treatment is required. Some believe it must be done after the size of 4 cm of endometrioma. There is controversy about whether to do surgical treatment or not in ovarian endometrioma according to the size, according to the fertility, according to the symptoms, according to the age of the patient, according to many factors. Okay? The problem with surgical treatment is that you may destruct part of the healthy ovarian tissue and the patient may lose some follicles. So this is a controversy at this point. If you are doing surgical treatment, you may damage part of the ovary. You may decrease the ovarian reserve. So this is the point of discussion, to do or not to do surgical treatment for ovarian endometrioma. And which size? Is it more than 4 centimeters only, or even less than 4 centimeters? So we aiming by surgical treatment to eliminate endometriotic tissue, to provide sufficient tissue for histologic assessment, and to preserve a maximum amount of normal ovarian tissue. Because, of course, ovarian endometrioma is space-occupying lesion, okay, so affecting the ovarian tissue surrounding. What about the ovarian reserve after surgery? As we mentioned before, surgical treatment of endometriotic cyst could be associated with unintentional removal or destruction of ovarian follicles, which can be identified by post-operative reduction in antral follicle and the anti-Mullerian hormone levels. So you can detect the ovarian reserve and identify the ovarian reserve after surgery of laparoscopic cystectomy for ovarian endometrioma. You may find decrease in the antral follicle and the decrease in serum anti-Mullerian hormone, which is a sign of diminished follicle in this ovary and affection of the ovarian reserve in this lady. So we wanted to know about general recommendations before surgery. Access, sorry, assess, assess the possible extent of disease and the size, number, and the location, whether unilateral or bilateral, of the ovarian endometriotic cyst before surgery. Also, meticulous preoperative planning should include a bimanual examination to check adnexal masses and the endometriotic nodules. Very important, the clinical examination. Ovarian reserve test as antral follicle count and serum anti-Mullerian hormone when future fertility is concerned. Also, pelvic ultrasound, transvaginal ultrasound, or MRI to determine the number and the size and the location, whether unilateral or bilateral, of the chocolate cyst, and if there is any endometriotic nodules, and extent of pouch of Douglas obliteration, how much the obliteration, presence of hydronephrosis, if the ureter is infiltrated or affected or constricted by adhesions and fibrosis, or the presence of hydrosalpinx, something very important. So these are general recommendation before surgery, and we can continue. Assess also tumor markers in case of suspicion of malignancy at imaging by MRI or ultrasound evidence of malignancy. Also, obtain informed written consent from the woman before surgery. She should be informed of all possible risks associated with surgical procedure, as we mentioned before. Handle the ovarian tissue as atraumatically as possible, so not to injure the healthy ovarian tissue. Still, in general recommendation, be aware of the risk of damage to ovarian reserve in endometrioma surgery. So, fertility preservation should be considered when the reserve is already compromised. Use of anti-adhesion measures or materials such as oxidized, regenerated cellulose, and hyaluronic acid products. Why? To reduce the occurrence of post-operative adhesions. Yes, it is important to minimize the occurrence of adhesion as much as you can. Let us go to laparoscopic surgery for ovarian endometrioma. First, use 3 laparoscopic working ports, as these may facilitate surgery. Yes. Inspect the pelvic organ and the upper abdomen. You can go clockwise or anti-clockwise. Do an inspection to the whole pelvis and the abdomen. Obtain peritoneal washing and the biopsies if you found ascites. Very important. And send for cytological analysis. Separate the ovary with endometrioma from the pelvic side wall, where it is usually adherent by adhesolysis, and try to visualize the ureter to be sure that the ureter is not injured during adhesolysis. The incision in the cyst should ideally be over the thinnest part of the ovarian endometrioma surface, or if this is not visible, on the anti-mesenteric border, so away of the hilum, away of the vascularity of the ovary, main vessels. So I should be away from them. But also If the ovarian puncture happened accidentally before you do the incision, while you are trying to dissect the endometrioma from the lateral pelvic wall, try to widen this puncture site or the opening in the cyst and deal with the case. Okay? Irrigate and inspect the cyst cavity to rule out malignancy. Any suspicious area should be biopsied for histological confirmation. Irrigate and aspirate thoroughly to check for hemostasis and to remove any remaining cyst fluid or blood clots from the abdominal pelvic cavity. Of course, we are trying to prevent occurrence of adhesions or infection. Okay, what about conservative surgical treatment of ovarian endometrioma? We have different lines of treatment of this conservative surgical treatment, like cystectomy, ablation by laser or by plasma energy, or electrocoagulation, whatever, monopolar or bipolar. Of course, bipolar is more safe. The combined technique, I will use combined technique like partial cystectomy and use electrocoagulation also in the same case. So this is called the combined technique. Or three-step approach. We'll see how to do three-step approach later on. Okay, so we have here 5 lines of treatment: cystectomy, ablation by laser, electrocoagulation, the combined technique, and lastly the three-step approach. What about cystectomy? After mobilization of the ovary and the drainage of the cyst, make an incision to reveal the cleavage plane. The use of cold cut at the edge of the cyst opening may assist in identifying the cleavage plane. So, when you are doing incision, don't do it by cutlery. Do it by cold cut. So, the plane of cleavage will be clear. And this is an important point. To aid dissection and the identification of the cyst wall, saline or diluted synthetic vasopressin solution 0.1 up to 1 unit per milli may be injected under the cyst capsule. This helps you to identify the plane of cleavage. Also, either saline alone or saline with vasopressin, because it will cause vasoconstrictor to the vessels and prevent bleeding. In some cases, a cleavage plane may not easily be identified after ovarian incision. In such cases, it may be better to take a small part of the cyst wall for histological diagnosis. Then use an ablation method. So you take a biopsy of part of the cyst wall to send for histopathological examination. Then you continue the operation by ablation of the cyst. This in case you cannot identify the cleavage plane. Use gentle traction and the counter traction with appropriate instruments to dissect the cyst capsule from the ovarian parenchyma. Yes, of course, you should be gentle so not to damage or cut part of healthy ovarian tissue. We want to minimize any loss of healthy ovarian tissue. Avoid use of excessive force to separate highly adherent cyst from the ovary, as this will likely cause tearing of the ovarian tissue, excessive bleeding, plus the need for coagulation or disarming, and this further damage normal ovarian tissue. So we should take care about this because it is important. Careful identification of cleavage plane and the precise spot bipolar coagulation is the key to achieve hemostasis to prevent unnecessary damage to healthy tissue. This is very wise. Ensure final hemostasis. After complete removal of the cyst capsule, bipolar coagulation, suturing, or intra-ovarian hemostatic sealant agents is important. Yes, it is important to avoid damaging the major blood supply at the highland. Sure. After removal of large endometrioma, it may be necessary to reconstruct the ovary and achieve hemostasis with monofilament sutures for a small endometrioma. On the other side, suturing is often not required, as the ovarian opening usually approximates spontaneously. So, if the endometrioma was big and the incision was big, I wanna to suture to close this defect and cause hemostasis using monofilament sutures. But if the ovarian endometrioma was small, this small opening will heal spontaneously. Approximation will happen spontaneously without any suturing. So you left it for spontaneous approximation and healing. Small cyst walls may be divided and retrieved directly through a port, but large cyst walls can be removed in a specimen retrieval bag. So if the cyst wall was big, yes, I need retrieval bag. What about laser ablation? Ablate the entire inner surface of the cyst wall using laser beam. Power settings of 30 to 55 watt for CO2 laser beam and 6 to 10 watt for CO2 fiber. Note the difference, and this is very important to adjust the power setting. Aim to vaporize endometriotic cyst lining only until hemosiderin pigment stained tissue is no longer visible. You cannot see the pigment stained tissue anymore. So the color will change from reddish to yellow or white. Use intermittent irrigation to maintain good visibility and to remove carbon debris. Ensure the border of the cyst opening is completely vaporized. So don't miss any endometrial tissue, please. What about plasma energy ablation? Ablate the entire inner surface of the cyst wall using plasma energy in coagulation mode set at 10 to 40 at a distance averaging 5 mm from the tip of the handpiece. And by the way, plasma energy ablation is more safe as regard not to injure the deeper healthy ovarian tissue. Aim to vaporize the endometriotic cyst lining only until, again, hemosiderin pigment stained tissue is no longer visible. Yes. To be sure that the endometriotic tissue became damaged. When cyst eversion is not visible, expose the cyst interior progressively to apply the plasma at an angle perpendicular to the inner surface of the cyst. Let us go to the next, which is electrocoagulation. As you can see in the picture, this is the bipolar, and this is disposable one, by the way. Bipolar electrocoagulation. We have bipolar and monopolar, and the bipolar is more safe. Coagulate the cyst lining by electrocoagulation systematically using bipolar forceps. The power setting depends on the generator and the type of forceps used, but 25 to 40 watt setting is frequently used. This is average. Start at lower power setting and adjust it, of course, to minimize the injury of the healthy ovarian tissue, depending on the effectiveness of coagulation achieved. The ovary should be cooled frequently with irrigation fluid. Don't forget this point. We say that with laser, we say that with plasma, we say ablation, and we say that now with electrocoagulation. Frequently irrigate by fluid to protect the healthy ovarian tissue. Okay, this picture shows the bipolar and the monopolar. Bipolar, the current extends between the blades only, not extending beyond the blades. This is the bipolar. But monopolar, the current extends away and may cause injury to a deeper structure or healthy ovarian tissue. So which is more safe? The bipolar. This one is more safer than this one. The key point is to use a very short coagulation time to minimize ovarian tissue damage, as the depth of destruction can be difficult to judge. Monopolar energy may be used in selected areas where there is fibrotic endometriotic tissue located at the hilum. A power setting of 15 to 20 watt is frequently used. Again, to the next topic or next line of treatment, which is combined technique. Combined technique means I may use two lines, like surgical excision of part of the wall, then complete by laser ablation or electrocoagulation or plasma energy ablation. So you remove part surgically, you excise part of the cyst wall, and the remaining part damaged by electrocoagulation or laser. So we will use both excision and ablation to prevent excessive bleeding and ovarian tissue removal or damage. Open and drain the cyst, followed by identification of cleavage plane. Strip 80 to 90% of the cyst wall and perform a partial cystectomy. Why partial? Because I didn't remove the whole wall of the cyst. Up to ovarian hilum. Then laser or plasma energy or bipolar can then be applied to treat the remaining endometriotic tissue in the remaining 10 to 20%. Suturing of the ovary may be considered to restore anatomy. In some cases, you may need it. What about the next line of treatment, which is three-step approach for large endometrioma? We have three steps in this line of treatment. First step involves opening and the drainage of endometrioma and inspect the cystic cavity and take a biopsy for histopathology analysis. Then, second step, give the patient medical therapy for 3 months in the form of GnRH agonist, subcutaneous injection monthly up to 3 months, like Gozerli. Okay? During which time the thickness of the cyst wall significantly decreases with atrophy and the reduction in stromal vascularization of the cyst. So I started by operation, just drainage and inspect the cyst cavity. Then, to be sure there is no suspicious lesion, and I took a biopsy for histopathology. Then I ended the operation. Then I gave medical therapy, GnRH agonist, for 3 months. Then the last step, do laparoscopy again. We call it second laparoscopy. Why? To complete the surgery in the form of either cystectomy, you remove the cyst wall, or CO2 vaporization, or bipolar dithermic coagulation, or plasma ablation of the cyst wall lining. So this is called 3-step approach for large endometrioma. Okay. The last line of treatment, you may need it if the case is complicated or recurrent endometrioma, or very large endometrioma with completely damaged ovarian tissue. You may need oophorectomy, but you should speak with the patient as regard the fertility concern. So, may be indicated, particularly in the presence of recurrent or large unilateral endometrioma or suspicious of malignancy. Of course, very important. Informed written consent from the patient is needed, and the fertility concern should be discussed. And as you see in this picture, this is the laparoscope inside, this is the uterus, this is the ovary, this is an instrument. We can remove this ovary, what is called oophorectomy, if indicated. But of course, this is not conservative surgery. Conservative surgery means we remove only the cyst, the endometriotic cyst, and leaving the healthy ovarian tissue to preserve the future fertility for the lady. In summary, we discussed today the definition and the prevalence, and we said many theories try to explain the occurrence of endometrioma, and we said that this is a cyst in the ovary containing altered blood, brownish in color, and causing severe pain, or presenting as a mass, or causing dyspareunia, or chronic pelvic pain, or dysmenorrhea. And this cystic lesion may be unilateral or bilateral due to presence of endometrial gland in the ovarian tissue. And different theories try to explain the pathogenesis of endometrioma. And we said our treatment goals is to relieve pain. Yes, the patient complain of severe pain and chronic pain. So to relieve pain, to avoid complication of adnexal mass or ovarian cyst like rupture, torsion, infection, or adhesions. Okay. Also, to be sure that it is not a malignant ovarian cyst, by taking a biopsy for histopathological analysis. Also, to preserve the future fertility for the lady, so to avoid the ovarian endometrioma from being large and damaging the whole ovarian tissue. So we are trying to preserve also the future fertility. And we said we have surgical treatment, mainly by laparoscopy, is the best line of treatment. And we said that laparoscopy need general recommendation before surgery, and we mentioned all of them. Then we said the laparoscopic surgery of ovarian endometrioma and the conservative surgical treatment of ovarian endometrioma like cystectomy, ablation by plasma energy, or laser, CO2, or electrocoagulation, monopolar or bipolar. And we said bipolar is more safe, or combine the technique, or three-step approach. We mentioned all of this. And lastly, we said oophorectomy could be a last choice in recurrent endometrioma, badly damaged ovary, large ovarian endometrioma, or suspicious of malignancy. Oophorectomy could be a solution in this case. And this is the last slide. This is the published article by the European Society of Gynecologic Endoscopy and the European Society for Human Reproduction and Endocrinology and World Endometriosis Society in 2017. They published very important article about recommendations on surgical treatment of endometrioma, and the many informations in this lecture coming from these recommendations. And this is the last slide in my lecture today. I hope it was a clear lecture and guide us toward the conservative surgical treatment of ovarian endometrioma in our practice. And thank you. Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University, and this is my blog site, dralaamosbah.blogspot.com. See you next lecture.